DTHF Research Meetings, your deep dive into the latest in research.
No. This is a talk that I gave at the HIV Clinician Society long-acting injectable meeting, which was in October last year, and Deborah and Lauren, who will speak next, also gave talks at this conference. So mine was essentially an introductory talk to look at long-acting products and where do these fit in the African context. So to start with, I thought it would be good to look at what are the options available to us. And the only thing in terms of long-acting injectables that are sort of registered in the country and available right now are CAB and cabrylpivirine injections. So CAB injections are 8-weekly intramuscular injections. I know a lot of people have been working on CAB long-acting PrEP studies. The number of countries with registrations for these products is increasing. I know South Africa registered for treatment as well as for PrEP, and there are a number of other countries where CAB PrEP is being registered. The studies that showed that these drugs worked in PrEP were the HPTN 083 and 084 worldwide studies, but a lot of that work was done in South Africa. I know a lot of our DTHF sites have worked on either one of these studies, and there are a lot of other sites in the country as well. And these studies continue in the form of follow-on studies and have shown real success of these products in diverse populations. In fact, to the extent that the studies were paused after DSMB that showed that injectable CAB was more efficacious at preventing infection than the oral PrEP. In the treatment setting, the Atlas 2M, and FLAIR studies showed success in maintaining viral suppression and showed non-inferiority to oral ART. You have to remember that these are injections. So when we're going through this talk, to think about implementation of that, we're quite used to giving out daily oral tablets, and health systems and implementation things change when you're giving out injections. And they are 3 ml injections. And if you're giving it as treatment, it's 3 ml in both buttocks. If it's CAB just PrEP, it's 3 ml in one buttock. And just from a treatment perspective, that being my bias, the vast majority of data has actually, for these products, is on switch. So someone is already virally suppressed, they're taking ARTs to the extent their virus is suppressed, and they're switching to a new regimen. They haven't been used as initial regimens. Now, there are other options coming up. We know about lenacapavir. Linda Gale has presented the success of the Purpose 1 study at IAS last year, which showed essentially in Purpose 1 there were no infections in the len arm. Len is given as a subcutaneous injection it has been in the stomach. They are now starting to look at other places where you could give it, potentially the arms. It's 2 injections, so 1 in each arm or 1 in each leg, or 2 different places in the abdomen. It's a subcutaneous injection, and len is also registered as an oral tablet for people with resistance for treatment, and just adding it to an optimized backbone regimen for people with multi-drug resistance, it shows benefit in that setting. Islatravir is a drug produced by MSD. It's a reverse transcriptase and translocation inhibitor in phase 3 development. It had a bit of a setback because it causes a reduction in CD4 counts, which is exactly what you don't need in preventing or in treating HIV. And there is a once-a-month tablet study that is coming up, and I know a number of sites are down as for the PrEP study, you're looking at this once-a-month tablet of islatravir. From a treatment perspective, using the 2 drugs above, the Ireland studies, which is very clever, ISL and LEN for islatravir and lenacapavir. The Ireland studies are looking at a once-a-week tablet for treatment. And we're hoping, I know J52 and my site in Googs are going to be running, we hope, the Ireland 2 studies. Fascinating for me as an adherence person, because I don't actually know if a once-a-week tablet is going to result in better adherence than once-a-day tablets. Then, so those are, I think, the things that are closest in coming. There are drugs that still don't have names, like MK-8507, which is a novel HIV-1 non-nucleoside reverse transcriptase inhibitor, also looking at a once-a-week oral regimen. And then there are various BNAB studies, but they're still in phase 1 and phase 2. And I know at J52, we've got a BNAB study looking at giving infusions of BNABs and then pausing oral ARVs to see if those BNABs maintain viral suppression. But the hopeful thing about that would be subcutaneous dosing every 2 to 6 months. So there are both oral and injectable and other formulations for these long-acting products. But what I want to point out right at the moment, just quickly, is that there is choice for PrEP. We have a 6-monthly subcut injection, a 2-monthly intramuscular injection, oral tablets, and vaginal rings. And just to point out what the options are for treatment, which is essentially nothing, because even though CAB and rilpivirine are registered in South Africa, they're not available. All the other medications are somewhat far down the line for treatment. So even though choice and options for choice are sort of definitely a way to improve people's adherence to both PrEP and treatment, choice is not yet a reality for treatments in our setting. So in Africa, what studies have we been doing? So there's been a lot of involvement in injectable studies in terms of treatments. The CARES study was presented at CROI last year, and it showed non-inferiority of CAB and rilpivirine long-acting compared to daily oral ARVs over 12 months. And the anxieties that people have about resistance to rilpivirine from background non-nuke resistance from our long-standing use of efavirenz have not come to fruition. So this is the first of the studies to present good results. This was a straight switch study, but done in an African setting. So looking at our clades of HIV-1 virus, and in our setting, more implementation science setting. The Impala study, Sheetal is PI on this study, which is being run at J52. Nigel Garrett is our South African PI, and then Fiona Creswell is the sort of overall Kenya, Uganda, South African PI. And this is a really interesting study looking at people who are struggling with adherence, getting them virally suppressed, and then looking at CAB or rilpivirine versus standard of care for people who are who have previously struggled with adherence, which for me is a good niche for these injectable options. We don't have results yet of the study, but there's month 12 data is coming. So hoping we'll see some of those results soon. And then this is a cohort study that we're running at our Gugulethu site, and Lauren will be presenting some data on that later. But we've got 3 different cohorts. We've got a cohort of, these are all adolescents, 12 to 24 years, either as a switch study, which is the standard sort of setting for these injectable studies, then more like Impala, looking at people who've struggled with adherence over time. And then our third group are people who are ARV naive, who we suppressed first with TLD and then switched. And Lauren will present some outcomes of those studies in a minute. Deborah is also going to present some more on the CAB side of things. So when you think about using these products in our resource limited setting, where do they fit? So if you look at the status of our PrEP and treatment epidemic in South Africa, this is where I'm familiar with, we're not that far off achieving our 1990-90 goal, and a number of sub-Saharan African countries have achieved their 1990-90 goal, but still only 74% of people living with HIV in the regions are virally suppressed. And this is possibly fewer than that, because often that 74% is based on people who've had a lab test, and there are quite a lot of people who don't come for lab tests. And what we do know is that children and younger people, adolescents and younger people, often are find it harder to suppress their virus. They find it harder to take their tablets every day. And also pregnant women and postpartum women deal with a lot of stigma and gender-based violence, issues of disclosure, and really struggle to take their medication. And poorer people often also struggle to take their medication every day. So there's substantial disparity in ARV access across districts within the same country. And part of managing our HIV epidemic means that we need to aim to achieve viral suppression. We know that undetectable viral load means untransmissible, and that people who have an undetectable viral load are not infectious. And it's people, if you look at the graph on the right, it is people with detectable viral load that drive the epidemic. Yet they are often the hardest to reach. So although we talk about 90, 90, 90 or 95, 95, 95, we need to be reaching those 5, 5, 5. And it is going to cost us more, and it is going to be harder. So they might be people where putting injection. So in the unsuppressed people, that might actually work out cost effective to use injectables that would cost too much for the average population on ARVs. So how do we implement this? So there are huge benefits. Firstly, there are no tablets. So for those who struggle to swallow or for whom tablets pose a risk of disclosure, and for many with pill fatigue, this is an enormous bonus. There's also more privacy. There's reduced stigma, the same reason that women often come to clinic to get their contraception as an injection or as an implant rather than take tablets. It makes it more private. Fewer people know what you're taking, and that reduces stigma and the need for disclosure. And in all the studies, I've put 3 studies up here, it has been acceptable and welcomed. What I've not put up here are quotes from our Affinity cohort, which I think Lauren will present, but people really enjoy being on injections, particularly people who have been on oral medications for a long period of time. Switching them off daily oral tablets onto a long-acting regimen has people feel really empowered. I like this quote here: "It might be painful, but it's better than pills," from a US male trial participant. So even though there are, we're not saying this is perfect, there are disadvantages, but it's better for some people, not for everybody. Going back to that choice. So what are the challenges? Essentially, we're spending our time now focusing on differentiated service delivery. We've got a lot of people coming through our clinics. Our clinics are overwhelmed. We're even more overwhelmed now because a lot of our counseling and support team has fallen away with the cuts in US funding. So we're trying to move people out of clinics and use differentiated service delivery. Like other studies I'm doing at site and looking at giving people 6 months of medicines people who've previously defaulted in a club setting to see if we can move people out of the clinics and rely less heavily on our facilities. However, the injections currently, cabin or pivarine, are not the most ideal. They require a deep intramuscular injection. Probably needs to be done by a nurse, even though there is some data coming on giving it in the thigh rather than in the bottom. A deep intramuscular injection to give it to yourself is pretty horrible. So I'm not sure how many people would actually do that. So at the moment, administration has to happen via a health worker. And instead of daily adherence becoming critical, it moves to visits becoming critical, because with both CAB and cabin rilpivirine as treatment, there is a very long tail of that medication. And if if your drug concentrations go below therapeutic and you haven't come for your injection, in the case of PrEP, you are more at risk of becoming infected and developing CAB resistant virus. And the same for treatment, essentially, your risk of having viremia and developing resistance to CAB or rilpivirine. So the focus shifts from daily dosing to tracking and tracing as being key. Let's move on to the next one. There are other challenges. The current formulations when we talk about long-acting, we get all excited as ARVs and HIV people with 2 months of injections. But you have to remember that in contraception, people have 3-year implants and 5-year intrauterine devices. So 8 weeks is really not that much to get excited about, but we do, because we've only been having daily tablets to date. And so we do still need to look at other formulations that require less frequent dosing. Rilpivirine requires cold chain. It's one of the reasons that J&J are reluctant to launch, even though they've registered in South Africa. They're reluctant to launch because it needs to be maintained between 2 and 8 degrees. And although we can do vaccines and things like that, it is still a challenge, particularly in areas or in countries without a stable electricity supply, for example. Both CAB and rilpivirine cannot be given with TB treatments that contain rifampicin. That's something that would need to be worked through in our setting, putting people back onto their TLD for the time they're on TB treatment and then re-injecting afterwards. It also doesn't treat hepatitis B. And we're missing data in children, and we're still learning about data in pregnancy. We have quite a lot of data on CAB from HPTN 084. We have quite a lot of data on pregnancy and LEN from Purpose 1, but very little data on treatment and very little on rilpivirine. So there are still missing pieces of information for rollout in our setting. We also have a potential risk for resistance. This did, however, not come to fruition with CARES, which is the one study we have results from our setting, and hasn't in Atlas or FLAIR either. And that paper will be published fairly soon. But the theory is that people in our environment may have a number of transmitted non-nuc mutations because of previous wide use of efavirenz and nevirapine. So the reason we switched from efavirenz and nevirapine to dolutegravir-based regimens was because there was a between 10 and 15% presence of transmitted non-nuc mutations. So and the presence of those rilpivirine-resistant mutations is a known risk for failure. But as I say, that is a theoretical risk. We haven't actually seen that come to terms in the studies that we have so far. Another risk is high BMI. In South Africa, 35.2% of women of childbearing age were obese, and that was in 2017. The drug needs to be delivered into a muscle. And you need really long needles if your BMI is over 30, and there's still a risk that the drug is not delivered into a muscle, which then alters the pharmacokinetics of release if it's delivered into subcutaneous fat rather than muscle, and can result in lower concentrations in people who are overweight. And then, of course, there's those very long tails. So if you decide to switch off a long-acting injectable, to go from CAB back to tenofovir or lamivudine, or to go from CAB rilpivirine injection back onto TLD, you need to be quite adherent to your oral medication for the whole period of the tail to try and not develop resistance to this drug as its concentrations disappear over time. And then, of course, costing. For me, this is the big elephant in the room. No one can tell us what these medications are going to cost. There are reassurances that they will be affordable, but in fact, as yet, we don't have costing. And modeling suggests that in order for us to afford these medications, it has to be targeted to those people who are going to cost us more already. And those are people often with reduced adherence. So what is the way forward? These are my last couple of slides. We need more data, which is great for us in the research field. We need data on populations who might most benefit. We need information on how to safely implement these drugs without causing any harm, particularly for those starting with a raised viral load. And we need data beyond clinical trials. We need to look at, do people come for their injections when they're not being phoned and hounded by their study coordinator and things like that. But CAB and rilpivirine is the beginning. It is, for those of us who've been here a while, it's like DT. We used T for the side effects, knowing it wasn't perfect, knowing it caused lipodystrophy for years, because it was what was available to us. And CAB and rilpivirine are what is available to us now. It's not the final formulation. There are, as I've said already, new and other things that are coming on. And as the registrations progress, our learning will carry on going. When lenacapavir is registered, then CAB and LEN are registered, so we can give them together for treatment. So we will learn as our registrations progress. So in conclusion, my thought is that we're not going to be able to offer long-acting injectables in the current formulation to everybody, and we will need to find a niche patient, just pragmatically. It might be great to offer them to everybody, but I think pragmatically, we're going to need to look at young people, non-adherent people, pregnant people, postpartum, for example. And adherence monitoring will have to do with more than dosing, will do with health systems' capacity to deliver, track, and trace in time. I think there's a fair amount of work that would need to be done there. And the final thing, of course, is affordability. We really do need to be able to afford these medications. And that is it for me. Thank you.
Okay, thank you, Catherine. It was wonderful. Thank you for, your slides are down. So
down.
Yes.
Okay.
I'm just quickly going to open the floor for questions. If anyone has a question for Catherine now, you can unmute yourself and ask, or raise your hand. That's what you prefer. Otherwise, we will move on to our next presenter. If you think of a question during the next presentation for Catherine, I'm sure she's still going to stay on. Then she can answer it another time later on. Sure. Okay, don't see any raised hands. No one unmuting, no one saying anything. No. There, Devorah.
You're muted. There you go.
Thank you, Catherine. I'm wondering if you were to target long-acting ART in a population, who would it be? I know you're saying that you focus on adolescents, but knowing that we're never going to have, or at least in the near future, we won't have stock available for everyone, who would you focus it on and why, in terms of a public health approach? Thanks.
So for public health approach, at the moment, I would go, you want to get the most bang for your buck, as it were. Mm-hmm. So I would go for pregnant and postpartum women, because we're protecting two people, essentially, by maintaining viral suppression in that population. Then after that, I would go for young people, because if you look at the risk of transmission, it is happening in 15 to 24-year-olds, often adolescent girls and young women. So they would probably be my second choice, because it's you really want to. So for me, it's we spend a lot of time talking about PrEP, and I'm more of a treatment person. So my sort of goal as a treatment person is to get everybody virally suppressed so that they're not going to transmit. And the people at risk are those adolescent girls and young women, and maybe just adolescents in general, and then pregnancy and postpartum. That would be where I'd start.
Okay. Thank you.
Okay, Yashna has a question. You can unmute yourself.
Hi, Catherine. Thank you for that lovely presentation. I just wanted to ask if you knew if there was any more commentary on, on what experts say on South Africa's background, non-nuke resistance and mutations in terms of the fear of, cross resistance with rilpivirine, and the reason, if there's a reason, if that may be the reason behind us not getting access to rilpivirine for treatment.
So the reasons that are given for access, it's a multitudinous thing for not getting access to rilpivirine for treatments, and it's got to do with the fact that there's a feeling that we can't do cold chain, and the fact that there might be this resistance to background resistance. But the background resistance will, as we move, we're already now 5 years away from using efavirenz, and it hasn't actually been shown that archive mutations will impact on this regimen. So, and I mean, CARES actually shows even there were people with rilpivirine mutations at baseline, or when they had their before they virally suppressed, they did genotypings of that virus, and they had rilpivirine mutations who were suppressed later on. And Monica Gandhi's study also shows that people with viral suppression, some of whom have non-nucleoside mutations, suppress on injectables. So I feel that we need more work. Like, we need to have a look at this. We need to explore what it actually looks like. But because there's been a sort of hold by J&J on launching rilpivirine in the country, we're actually not going to get the opportunity to do that, because they're not supplying more drug for research, and it's unaffordable at this point. It is 700 euros, and I know there's 700 euros per dose for just rilpivirine at this point, if we had to buy it in from Europe, for example.
Thank you. 700 euros is a lot.
A lot.
Okay, great. Catherine, I think we'll move on to Lauren's presentation. Thank you so much for taking those questions. Okay, so Lauren, you can go ahead and start sharing your slides while I'll give a brief introduction. So now we will have Lauren Jennings presenting. She's a clinician researcher at DTHF and I think she's still a PhD candidate, but she may have finished. I'm actually now not sure anymore. And her research focus. She's still a candidate? Okay. And her research focuses on HIV treatment and medication adherence. Her key interests are novel ARV monitoring methods, treatment innovation through new delivery methods of ARVs, and access to choice for those on HIV treatment. And today she will talk to us about how long-acting ART could help adolescents and young adults. So over to you, Lauren.
Thank you, Nadine. Hi, everyone. So today I'm going to be sharing findings from the Affinity Study, which will demonstrate how long-acting injectable ART could help adolescents and young adults living with HIV. So this is a presentation, as Catherine mentioned, that I gave at the Clinician Society meeting last year. So we know that there are approximately 3.4 million young people aged 15 to 24 living with HIV worldwide. And looking at the trends since 2010, we can see that there's very little change in numbers over time. And this is partly driven by the fact that young people account for 33% of new HIV infections worldwide, with a quarter of all new infections occurring in women and girls aged 15 to 24. So where do we stand in terms of treatment? The number of adolescents on ART has rapidly increased, but adolescents have the lowest adherence rates of all age groups. And only 23% of adolescents were fully virally suppressed in the preceding year in one of the studies that was done. So adolescents continue to perform poorly on the 95-95-95 targets compared to adults. And for adolescents, there are significant barriers to HIV treatment, and these include retention and adherence, stigma, fear of being judged, fear of disclosure, treatment fatigue, and the adolescent lifestyle. So while there has been a decrease in AIDS-related deaths in young people of 24% from 2010 to 2019, this is a much smaller decrease than has been seen in other age groups. So we are doing the Affinity Study, which is using injectable CAB and rilpivirine, which is given every 8 weeks. It's not the ideal regimen, as Catherine mentioned. Some of the drugs are not robust. They require a cold chain. It requires an increase in clinic visits and specially trained staff. But currently, it is the only long-acting ART regimen that is ready for implementation. So while we wait for the development and approval of different long-acting regimens, we need to explore the implementation in low and middle income countries and niche populations who may benefit the most. So long-acting treatment may be the solution to adolescent ART adherence challenges. So the objectives of the study were are to look at the acceptability and tolerability of the injectable method and the feasibility of delivery in a community setting. Then secondly, to look at adherence to study visits and to injectable product. And third, looking at the efficacy of long-acting injection regimens in each cohort. So on the right there, I just have a picture of our clinic, which is just to the left there of the Guguletu Day Hospital. So I won't go through all the inclusion criteria, but just to highlight that we enrolled people aged 12 to 24 years who were on or initiating first-line ART, and they had to be virally suppressed to less than 50 copies per ml at the time of switch to injections. We also excluded anyone with known resistance to any of the ART drug groups in the study, so NNRTIs or integrase inhibitors. We didn't do baseline resistance testing, but we determined this through a review of the clinical history, clinical folders, seeing if there were any previous raised viral loads on these regimens. So this is the study schematic. We enrolled in 3 cohorts. So cohort 1, they were on first-line ART and they had been virally suppressed for more than 1 year. So we could immediately switch them to injectables. Cohort 2, they were also still on first-line ART, but they had recent evidence of poor adherence. So either this would be a gap in treatment or a viral load a raised viral load. So what we did for them was we gave them adherence counseling and continued their oral standard of care until they were virally suppressed, and then we switched them to injectables. And then our cohort 3 was ART naive, so people who had never been on treatment before. So what we did was we gave them the oral standard of care and then tested their viral load, and if they were suppressed, we were able to switch them to injectables. So at the point of switch, each participant had the option to choose an oral lead-in, which would be 4 weeks of oral CAB and rilpivirine, or they could choose to just go immediately to the first injection, which most of them did. So then the injection phase would include injections every 8 weeks till week 48. And then after that, we had an extension phase, which was a donation of extra injections for our participants. And at this point, it was 2 years. And then after that, we will switch them back to the oral standard of care. So we had 168 participants that we screened. 34 did not reach the injection phase for a variety of reasons. Some were lost to follow-up, some were not able to suppress. And 134 of our participants reached the injection phase. If we look at the demographics, we can see in the first row the numbers in the different cohorts. And also we can see that we had predominantly female participants in cohort 1 and 3, but there were slightly more males in cohort 2. The mean age across the groups was about 19 to 20 years old. And you can see the different percentages as well of participants under the age of 18. Most of them were in cohort 1, but we did have some in cohort 2 and 3. So this was our first sort of look at the viral loads, which is at 24 weeks. We had, out of the 134 participants who started injections, 133 attended the visit. So we had 1 participant who was lost to follow-up. And of those, 131 were suppressed to less than 50 copies per ml. And then you can see that the 2 viral loads that were above 50 copies per ml were still very low level viremia. And both of these participants resuppressed prior to their next injection date. Then looking at our week 48 outcomes. So currently we have had 131 participants who have reached this time point in the study, and 128 or are expected to have reached this time point in the study, and 128 have attended the visit. So that's 97.7%. We've had 1 participant who transferred out, moved to a different province, and 2 who are lost to follow-up. So 124 of the participants had a suppressed viral load to less than 50 copies per ml, which is almost 97%. And of the 4 viral loads over 50, you can again see that they were very low level viremia, and that all resuppressed prior to the next injection. Looking at adherence to injection visits, so this graph is in a log scale. So you can see that of the 1,115 injection visits that we've had, only 2.2% have been outside of the visit window. So we have a target date, which is 8 weeks after the last injection, and then we have a window of 7 days before and 7 days after in which the participant can come and get their injection. So most of them have been right on target. Only 3 participants have required reloading, which means that they were more than a month late and they needed to restart the injections with a loading dose. In terms of retention, we've had 2 study withdrawals in the injection phase. So 1 transfer out, and sorry, that should be 3, and 2 lost follow-ups. And then we've had 3 study withdrawals within the extension phase. So that's after week 48, another transfer out and another 2 participants who were lost to follow-up. In terms of safety, we've had no drug-related serious adverse events to date. We had 1 pregnancy on the study, which the participant had an elective termination and remained on the injectable study product. And we've had 4 cases of TB. So what we do when somebody is diagnosed with TB is we pause the injections, we switch them to TLD for the duration of the TB treatment, and then once they've completed their TB treatment, we can switch them back to injectables. So all participants who reached week 48 to date have opted for the extension phase of injections. So opted not to switch back to the oral treatment. Subsequently, 1 participant elected to switch back to TLD. Okay, and then we've done some qualitative work on this study as well. So there are several themes that have emerged. So in cohort 1, which is our virally suppressed cohort, some of the themes were that they felt as if they were living life fully, as though they were HIV negative. And they also felt that the injections simplified their life. So some quotes, a 16-year-old male said, "I like the fact that I can be stress-free. Like every day when I wake up, I don't have that feeling that I have to drink these pills. I have to do this and that." And a 22-year-old female said, once they get the injections, they know that now the weekend is here and now they don't have to worry about the pills and what they're going to do. They will just have fun. And in cohort 2, who are the adolescents who had adherence challenges, they liked that the injections were discreet and removed the possibility of unplanned disclosure. And they also felt that injections removed the burden on self and others. So this 24-year-old male said, "I feel so good because I do not have to worry about taking my medication at a certain time or waiting for people to leave the room so I can take it." And this 20-year-old female said, "With the injectables, you don't have to, even if you want to go somewhere, you don't need to carry things and stuff, you see. You just get the injection here at the clinic and then you chill and go." And then in cohort 3, which is our ART naive group, they said that the long-acting injectables removed the additional worry of forgetting to take the pills. So this 22-year-old female said, "Yes, because you would find that it has maybe been 2 days without taking pills. I would get startled and think, no, man, I must take them." And this other 24-year-old female said, "It was difficult as no one knew at home. I would try to hide them or fetch treatments and no one saw them. Now I feel free on the injection." So we can see based on our outcomes and our qualitative findings that these long-acting regimens are filling a crucial gap in young people's experience of HIV treatment. And while it may be unlikely that they will be available for all people living with HIV, they might have use in specific populations such as adolescents and young people who are experiencing significant challenges with oral medication. And I'd just like to thank the other investigators, the site team, and the Affinity participants. Thank you.
Great. Thank you, Lauren, for a great presentation. I will again open up the floor for some questions. Anyone who would like to ask Lauren something can unmute themselves or raise their hand. Ketumetse, you have a question? Go ahead.
Thank you so much. I'm not sure if my question is related to what you're presenting, but it's some sort of a side question. It's a different tangent, but I just wanted to find out if you guys collected information on CD4 count. I'm just trying to check if one can look at the burden of advanced HIV between the cohorts that you had. If people are, is the burden of advanced HIV amongst people that are newly initiating, that means that probably they're initiating late, or is it amongst people that have initiated before, and like what you have classified as the ones that are have poor adherence?
Yeah, so thank you for the question. We have collected information on CD4. We did CD4s for all our participants. don't have that information to share with you today, but I think it is a good question to raise, particularly because long-acting injectables don't actually take away the burden of all tablets, especially if you do have advanced HIV, then you will need to be on other preventative medications. So that is something to note, although those are not lifelong medications.
Can I go, Nadine?
Yes, I was going to say, LGB, go ahead, ask your question.
Thank you. Thank you. First of all, well done, Lauren. That's really nice presentation. And thanks, Catherine. I just got the tail end. Apologies. I had to come across from another meeting. So apologies for missing a good chunk of your talk. But thanks for doing this. My question, Lauren, is around those little viral load blips. And maybe just I'm asking the question on behalf of everyone so that they get this answer. I think it's an important one. Are you worried about that in terms of the U equals U framing? And what do you think's going on there?
Yeah, so I think when we saw get these results, our first thought is, what is the BMI of this participant? Have we used a long enough needle to get the correct delivery of the medication? Is it because the drug levels are not as high as they should be for whatever reason? So those are the things that are going through our mind. We haven't, it is I think with the U equals U, correct me if I'm wrong, but it is sort of, they've shown that up to 200 copies is still okay. So it isn't such a concern for that, but I mean, we wouldn't want to see this happening frequently. So it is something to keep an eye on.
Thanks, Lauren. Yeah, I mean, I would just, and thank you. I think that was a really good answer. I would just add that, just really for everyone's understanding, that out of the review, copies up to 1,000, it was very unlikely. That's how it's framed by the WHO in their policy statement. Very unlikely to see transmission of HIV. But you're quite right. They stipulate that U equals U is applicable for anybody who has undetectable viral load. So regardless of what your level is, if your lab decrees this is undetectable, and many labs in Africa, it'll be 200 and below, then that would be considered undetectable. And there, WHO actually says that we should say 0 chance of sexual transmission. So that doesn't apply to vertical transmission, but sexual transmission has a 0 implication. So I think you can reassure those young people around that. And I think it's just quite interesting that these little blips happen from time to time, and it's the value of following up and seeing what happens. So yeah, I guess we don't know though if that kind of niggling viral load has implications for immune activation and potentially sort of other impacts that the virus has on our immunity over time. But thanks, that's great. Thanks.
And just to add that we have collected plasma that we can do PK. So we haven't done that yet, but it would be interesting to look at.
Yeah. Thanks.
Okay, Satya, you can go ahead and quickly ask your question, and then we'll move on to Devorah's presentation.
Thank you, Nadine. Lauren, I want to ask you that in the methodology, you've put oral lead-in as an option. Why is that an option, and how does that work? Can you just explain a little bit?
Well, that's a directive from the manufacturers, from the drug companies, who have said that the oral lead-in should be optional. Actually, Catherine, I don't know if you can remind me what the rationale for that was.
I think it was initially it was because people were worried about hypersensitivity and wanting to take drug up front. So before you got 2 months injected into you, you knew it was beforehand. But then it basically got to the point where we hadn't seen any hypersensitivity. And so it kind of became, do you really need this? Do you not? But some people still preferred it. They are in charge of their bodies. They might want to try it first of all. But to be honest, most of our participants weren't interested in it. So the company insisted that we make it an option, and we made it an option, and most people haven't chosen to use it.
So that
Satya,
Yes.
I would just say it's in the package insert. That's the way it's framed in the package
Okay.
insert.
It's not because of the pharmacokinetics or the pharmacodynamics that
No.
requires it.
No,
Okay.
it's not like Len. It's not like Len. Len needs those 2 loading doses before you give the injection, but cab and rilpivirine, the 2 loading doses are the injection 0 and 1, 4 weeks apart.
So, Catherine, I want to be clear to everyone so we get the language right. So this is a lead-in as opposed to a loading dose.
loading.
The 2 get conflated
Yes.
all the time, and so
Yeah.
that's the difference.
Thank you.
Okay, great. We will move on to Devorah's presentation. Sorry, Devorah. I'll just give a brief intro. So our next speaker is Dr. Devorah Joseph Davey. She is an infectious disease epidemiologist and is an honorary associate professor at the University of Cape Town and an associate professor at UCLA. She's a PI of several NIH-funded studies. She evaluates interventions of HIV prevention, PrEP, and STI diagnostics in pregnant and lactating women. And since 2003, she has led research in Southern Africa informing culturally relevant interventions to reduce HIV's impact on women and families. And today she will talk to us about long-acting PrEP in pregnancy and breastfeeding. So over to you, Devorah. Thank you so much.
Thank you, Nadine, for the invitation. And like my colleagues, Catherine and Lauren just said, this is a presentation from last year at the Southern African HIV Clinician Society on long-acting PrEP in pregnancy and breastfeeding. So just for some background, there's a persistent high incidence of HIV during pregnancy and breastfeeding. In this meta-analysis that was done a few years ago of 37 studies, the estimated incidence was about 3.6 per 100 woman years. Incidence was associated with age, partner serostatus, and calendar time. And you can see here in the stratum specific estimates that even breastfeeding only or pregnancy and breastfeeding, the pooled incidence rate was still above 3 per 100 woman years, indicating this is really a target population to focus on for prevention, primary prevention of HIV. There's many reasons why pregnant and lactating women are at higher risk, including biology and sociobehavioral factors. Biological factors include hormone changes, and then genital tract expression of cell receptors, immune adaptations, STIs that can be higher as well during pregnancy, postpartum micro and macro trauma, and then breastfeeding. Sociobehavioral factors are common across all populations, but could be different during pregnancy, including condomless sex, sexual networks, intimate partner violence, substance use, and stigma. So 1 in 4 HIV infections in infants is due to pregnancy and breastfeeding. And so here we see that in East and Southern Africa, and our region in the red bar was 16,000 infections in 2023 attributed to the mother acquiring HIV during pregnancy and breastfeeding. So a third of infections are attributed to incidents during pregnancy and breastfeeding. Building on prior studies, we conducted a PrEP-PP study, which is PrEP in pregnancy and postpartum, which was using oral PrEP in 1,300 pregnant women. And we saw that most women did start oral PrEP. Persistence dropped by 50% in 6 months, which is during postpartum period. And you can see some of the barriers here to oral PrEP, including changes in sex risk, exacerbated side effects that co-occur with pregnancy side effects, demands of a newborn, access and migration, interpersonal violence in relationships, and stigma. And so it's important really to think about these barriers as we address other interventions to improve PrEP use in this population and others. In this study, and we published this last month in Lancet HIV, is that seroconversion in our study of 1,300 women, most of it was in the postpartum period. So 1 pregnant woman and 15 postpartum women seroconverted. 2 infants also acquired HIV, and that was 13% in seroconverters. 1 was in labor and delivery, and 1 was following breastfeeding. And mostly the PrEP use in seroconverters were due to discontinued PrEP use. So 10 people started PrEP, but they discontinued. 4 people took it intermittently or stopped 30 days or more prior to seroconversion, and 2 people never started PrEP. So it's really important to address the discontinuation of PrEP, especially in the postpartum lactating period. So new PrEP modalities that we went over earlier with Catherine's presentation is injectable cabotegravir, an intramuscular injection every 8 weeks. Lenacapavir is a subcutaneous injection every 6 months. And a pivarine ring is inserted into the vagina every 4 weeks. I've included differentiated PrEP delivery just as another way of overcoming some of the barriers, which includes multi-months dispensing, pharmacy or community rapid queue, and the use of HIV self-tests for rapid pickup. So all of these together can really improve upon some of the barriers and addressing some of the barriers that we see commonly with oral PrEP use in this population. So the potential benefits of CAB, this is a study done by Lee Johnson and colleagues that was published last year. And in the mathematical model Timbisa, which I think a lot of you have heard of, without PrEP, there's going to be 1.3 million new HIV infections in South Africa in the next decade, including 100,000 pregnant and breastfeeding women, 16,800 infants at or before birth, and 35,000 infants through breast milk. And what we found is in different scenarios, and in the models informed by ongoing research, that the incidence was greatest either in the CAB-LA arm. So you can see here on the right, in the CAB-LA arm, we had a 41% reduction in HIV incidence in pregnant and breastfeeding women, and 43% reduction in infants. And when there was a choice between oral and CAB, we saw similar reductions in incidence in both women and their infants. And it appears to be safe. Injectable PrEP appears to be safe with the data that we've seen, which has been updated since this time, actually, in almost 300 pregnancies, and was published by Sinead Delaney and other colleagues, showed that it was safe when compared to oral PrEP. And it also appears to be appropriate in PK studies. And we have a PK study as well that's ongoing. Pregnancy outcomes with CAB-LA are also similar to background rates and in those without any CAB exposure. And data on lenacapavir and 105 completed pregnancies from Linda Gale's study and colleagues in New England Journal of Medicine also showed that there was no difference between len and oral PrEP. So well done to both teams to really putting in the data around pregnancy so that we can really understand the potential risk and benefit in these populations. Data collection is continuing on safety, and for CAB-LA and then we have about 200 to 300 births, and so we can rule out some of these very common side effects, but some of the more uncommon side effects, there's insufficient data. So the World Health, WHO, is continuing data collection, especially with those with partners, including Desmond Tutu on CAB-LA and in the future, lenacapavir exposed pregnancies. So this was also in a discrete choice experiment that we did with colleagues in East London, Cape Town, and Gaborone, and 450 women. And you can see some of the quotes here when we asked about different types of acceptability of PrEP in pregnant women. And you can see the description that we used in this discrete choice experiment.
DTHF research
and here
meetings.
You can see that
You deep dive
pregnant
into the
breastfeeding
latest
women really
in
put
research.
fewer refills. So if the coefficient is greater than 0, it's on this side, meaning that they wanted fewer refills. They wanted a product that had less discomfort or side effects. Really vaginally inserted were less likely to be acceptable. And then combination prevention with HIV and STIs was also found to be more acceptable. Okay. And so for the need for choice, we also published this study that we asked if injectable PrEP were approved as safe to use, would you prefer to keep using oral PrEP? And you can see that 75% of women, both in South Africa and Kenya that were using oral PrEP, would prefer to switch to injectable PrEP. And the Prepared to Choose study, which most of you all know is an ongoing implementation study. And through September of last year, we had about 60 pregnant and breastfeeding people in the study. 83% had started CAB-LA, and people reported that they liked the long-acting prevention, and data is continuing. So really, what we advocate is let's collaborate together to improve access to and counseling for effective PrEP use, including injectable, long-acting PrEP, simplify PrEP access by removing barriers, including differentiated delivery in postpartum, and advocating for rapid, cost-effective choice, including LEN, CAB, and DVR. And health education and ongoing training of providers is going to be essential. I want to thank my dream team listed here. And I went over quickly, so we have 2 minutes for questions if anyone has any questions. Thanks so much.
Thank you, Devorah. Yes, as Devorah said, if anyone has any questions, please raise your hand or unmute yourself and ask away.
If not, I'll share the slides so you can go through them with more attention and let me know if you have any questions about pregnancy.
That would be great. Thank you. Okay, it looks like you blew everyone away with your data. So there aren't any questions. As far as I can see, no one raising a hand. Okay. Well, thanks to Devorah for making up some time. Oh, wait, now there's a question. Ntando, you can unmute yourself.
Thanks, Nadine. And thanks to Devorah. I sort of wanted to go back to Lauren's question, Lauren's presentation, and I guess it applies for all of us. But I think the long-acting for treatment is, I really liked the acceptability, which really looked high, and I really wanted to hear what the next steps from their perspectives are, because I think Catherine also referred to acceptability, from the communities and people who use the products. But I'm wondering about acceptability from those, from the high level that has to ensure that this is rolled out. Any next steps around that in those discussions?
I can maybe say something. So far, I think it's disappointingly few. Basically, because the company is not going to be rolling out the product and not launching the product, everyone is kind of stuck. So, yeah, essentially, not much is happening at government level at this point in time from a treatment perspective, not from PrEP. I think Linda Gale, I don't know if she's still on, but would be best to speak to the rollout of PrEP. That's definitely on the cards, but treatment is still far away. In fact, we're looking at essentially not being able to use rilpivirine at all for treatment. We would have to wait for the CAB and LEN studies to come out, I think, before we get injectables for treatment at this point.
Yeah, and in fact, the companies are collectively a bit of a problem. So Janssen has the rights, the African rights, for both products as treatment. And GSK can commercialize the CAB locally because there is a GSK office, but they have chosen for PrEP not to commercialize CAB in the private sector. So they are not going to do it in the private. So you won't be able to get CAB for PrEP in the private sector. They are only doing a public sector price. So despite the fact that, all these trials have happened here and we are, so engaged, both companies, I think, have been less than fully engaged around full access, which I think is very disappointing. And I think I call on the activists to apply pressure, to keep working on it. Yeah.
Increased demand.
Yeah. I think clearly there's a lot of demand, and there's that balance between sharing these outcomes, widely, and then there's nothing that happens in terms of making sure it's accessible. Especially, I truly understand what's happening from PrEP perspective, but I think for treatment as well, I'm not sure how that really would look.
It's a shocker. So, you know, I think I think it's all about price and money. That's all it's all about, sadly. So,
And
GSK won't,
demand. Yeah.
Yeah, I mean, demand in
Which is
as
the
much
same.
as, I mean, I think the demand, like everything, if the product was there, the demand would grow, you know. But there's reticence because, you know, so we're not advocating it in the private sector because it hasn't gone into Dis-Chem and you know, even though it's approved, the CAB for PrEP. So they're only going to come in with a price that can go out on government tender. So, you know, so that's restricted. And I think it's because of tiered pricing, and they're worried about not getting the value they get in the, you know, in North America, Europe. So it's unfathomable, and it makes me depressed at a depressing time. But you know, I think we have to keep. So I have asked the Clinician Society to pick up the commercial CAB for PrEP. We have tried to, and Catherine went all the way to DC, you know, to advocate around Affinity Study and typical other results that we're seeing. I mean, the CARES study, Impala will be coming out. Yeah, you know, so I think we just have to keep shaming organizations. And, you know, in this very lean time of donor funding, to turn to the philanthropists to say, you know, is there pressure that Gates and others can apply as well in this setting? I think the feeling is this, Catherine hinted at it, it's a suboptimal regimen, and therefore do you know, try and get the price down, try and get generics, try and move this forward, or do you just hang on for a bit? A few more adolescents will die with unsuppressed viral load while we wait for the, you know, these are public health decisions, you know, that it is what it is, you know.
Yeah.
So,
Could there be a case of, I mean, just thinking scenarios with whoever who buys, and we say in terms of injectables, maybe let's roll out and virally suppress with long acting, and perhaps that kind of makes a case for PrEP. And is that something that could be, I don't know.
sorry, just say that again for me, Ntanda.
So, I mean, I'm thinking if the government, and hope they don't, they say okay, let's make sure that we get long acting for treatment, and that sort of compensate for, in a way, you know.
I've got it. So the amount, no, I think there's a finite amount of money. You're absolutely right. So I do think the way Catherine and Lauren, you know, projected this is maybe we need them to understand this is not, shouldn't be for everyone. It should be a limited, you know, bang for the buck population where we direct them to how many doses we think need to happen and why. So, you know, maybe those kinds of discussions need to happen. A thought crossed my mind. We've once before taken companies to court on you know, on reasons of competition. So if you can get this drug elsewhere, we should be able to get it here, but we need to be able to get it at a more affordable price, whatever. So, you know, maybe one of our young people could be a defendant or whatever you call it, a plaintiff. And you know, they really don't want to go off injectables. Maybe we need to get Mark Hayward and others involved again in something like that. We can think about it.
Yeah,
It does
Chloe Orkin did mention in her Glasgow talk that there are 14,000 people receiving caminolpivirine as treatment in Europe. So it's not like it's not being made or manufactured. It is being manufactured.
It's being manufactured by
ViiV. That's ViiV, though.
Distributed in the north, and it should have been Janssen, but Janssen's pulled out of global health completely. They just don't even want to.
Disappeared.
Yeah. Shocker. But there's everything that in me believes we take this on. But you know, anyway. So I think the start of an important conversation, and maybe we need to put our heads together and think: can we take more of a lead here? You know, is there something more we can be doing as an organization for advocacy? But thank you to the team for great presentations, and thanks, Devorah. It's always great to catch up. Okay.
Thanks for inviting
Okay,
me.
great.
Thank you, everyone.
I think that's it for
Bye.
today's meeting. Thank you everyone who presented, and everyone else for their questions and for attending, and see you next time.
DTHF Research Meetings, your deep dive into the latest in research.